So let's go.
Okay.
All right. Good morning, everyone, on this lovely October 15th. Thank you guys for joining the Galion Safety Council meeting today. As attendees come in, we'll get some people, they're starting to log in now. We'll give it just a minute, make sure everybody gets on. We'll have a presentation today about the common workplace industries of the hand and upper extremities. There's been a lot of stuff circulating about people working from home and the ergonomics of using laptops sitting on the couch and all that. So it'll be an interesting presentation. If you want to go ahead, turn it over to Stacy to give us some BWC updates.
Hello, everybody. I hope that you're all doing well. I just have a few really brief updates from the BWC, and then I'll hand it over back to Miranda, and we can get started with the presentation. So I wanted to make sure that everybody was aware that the information that I shared at the last meeting, that we were waiting on approval from the board regarding the dividend that would be equal to 100% of the premium that you paid for the 2019 policy year, has been approved. So those are going to happen. We are going to start cutting checks here at the end of October. So yay, it's time to celebrate. Wanted to also make sure that you were aware we've made some changes with our Division of Safety and Hygiene. Many of you I know are aware and familiar with our Ohio Center for Occupational Safety and Health, we call OCOSH. Used to be located in Pickerington, Ohio. No more. That location is no longer something we're going to be using. The folks that were located there have all been or are being transitioned down to our downtown Columbus office located at 30 West Spring Street. They're going to be on the 25th floor. There will not be any changes with how to contact them directly. Phone numbers and email addresses are all the same. So you don't need to worry about how would you reach anybody at OCOSH. They're just going to be at a different physical location whenever it is that we actually go back to working in the office. So I wanted to make you aware of that. I wanted to also go over some of the classes. Last time I shared some of the ones that were being held in October, and I wanted to go ahead and just mention a few that are again left here at the end of October, and then some coming up in November. We have, first of all, job safety analysis on October the 27th. That's at 9:30 a.m. And we have the second one on October the 28th, which is developing a driver safety program. Third one is on November the 5th. It's an accident analysis half-day class. And the fourth one is on November the 12th, which is a hazard communication half-day workshop. The fifth class is electrical basics, held on November the 17th. And the last one is on November the 18th, and that is another lockout, tagout, and safety related work practices class. These are all going to be WebEx meetings or virtual meetings, so you would need to register for them through the BWC Learning Center. And Miranda did pass out the handout that I was referring to. She sent it out to everybody, so if you don't have that handout, you can reach out to me directly. She did provide my email address last time, but I'm happy to give it out again. If you don't have my email address, it is Stacy, STACY, dot, the letter N as in Nancy, dot, the number 1, at bwc.state, and that's spelled out STATE.oh.us. And then, of course, obviously, you can always call me. My cell phone number directly is 419-606-4617. And then I just wanted to give one quick plug for our Division of Safety and Hygiene. Wanted to make sure that everybody is aware that they are still very much available to help you in whatever way that they can virtually. David Moronk is your assigned industrial safety consultant, and John McLean is your assigned industrial hygienist. So if you guys have any questions regarding either one of those fields, they are there to help you via email, phone call. They are trying to do some virtual consulting, real-time consulting through the use of, different technology. So, if you think that there's a way that they can help you, please reach out. I have their contact information. I'm happy to share it. If you guys have any other questions, please don't hesitate to reach out. Miranda?
All right, thanks, Stacy. I'll email that flyer back out again after, kind of like we did last month as a recap of today, just so everybody has it. And then we did get another thing from the BWC yesterday to hand out. So I'm trying to decrease the number of emails you guys have from us. I know the daily COVID update emails are overwhelming to me, so I'm trying to at least make it all content driven for everybody. We are ready to get started. Just a few housekeeping things. If you guys at the bottom of your screen, if you have questions that you would like, you can type it in the Q&A section and we'll get to those at the end of the presentation. But Amy, if you guys are ready, we will go ahead and get started from your guys' side. Thank you.
Okay, Dr. Nappi is here. We're going to go ahead and get started. If there's any technical issues on your end, let us know, okay?
Morning, boys and girls. My name is Jim Nappi. I'm a hand surgeon down here in Columbus, and we're going to talk about some of the common workplace injuries and disorders that go on in the hand and the upper extremity. If you have technical issues, make sure we know during the course of this.
Yeah, no, it's okay.
Okay, some of the more common things we will see traumatically are going to be lacerations, crushes, avulsions, amputations, puncture wounds, fractures, sprains, dislocations. We also deal with the repetitive motion disorders, tendinitis, nerve entrapments, and now with the mass of people working from home, it is known as the poor ergonomic workstation disorders, including myself at my own home computer. If we look statistically from back in 2016, most of the common things that are filed and dealt with are going to be overexertion, bodily reactions, the sprains, strains, things of that nature. Fall slips do occur, and there's a fair number of folks dealing with contact with either moving objects or equipment. Sprain, strains, ligamentous tears are extraordinarily common. Soreness, cuts, laceration, things of that nature. Fractures are much lower in occurrence. As we look at some of the disorders going on of interest, fractures seem to be high in presentation along with multiple injuries. That means when you broke something, you also had something else occur simultaneously. Of interest, as we look overall at the numbers, the infamous carpal tunnel syndrome factors in extremely high in this as a repetitive activity disorder. A lot of this comes down to nothing more than what goes on as we mature and spend more time in the workforce, and what is our overall likelihood of having problems occur because we have gotten quote unquote fat and sassy, as I like to describe myself as becoming. As we look at these things, all of these come into play with occurrences. Repetitive activity, tendinitis, the most common that we'll talk about are listed there for you: Decker veins, tennis elbow, trigger fingers. These things happen as we begin to mature. The maturity factor usually starts setting in around age 40. We are more prone merely by age to develop some of these disorders with our activities. Decurvainous tendonitis, probably the most common repetitive activity tendonitis that occurs at the wrist. It actually happens at the very base of the thumb, where you have an inflammation of two tendons at the radial styloid that create thumb motion. It primarily presents as pain with thumb and or wrist motion and stress. If one would take the fingers and grab the thumb and then turn the hand towards the little finger sign, one elicits a positive Finkelstein test, almost pathognomonic for the process. The good news, most of decurvains can be self-limiting. Primarily treatment to begin with would be resting and splinting and avoidance of thumb motion. A carpal tunnel splint, however, will be inadequate. Here, we want a splint that immobilizes the thumb. Non-steroidal anti-inflammatory drugs are beneficial, and a combination of splinting, rest, and non-steroidals will probably remedy 40 to 50% of decurvains within 3 to 4 weeks. Next option is steroid injection, extraordinarily painful at time of being done. However, about 98 to 99% of patients will respond within a 1-week period of time. Very, very efficacious for treatment. Surgical intervention for decurvains is almost never necessary. When done, if one reads the literature, up to a 50% complication rate from that surgery can occur. Therefore, some surgeons will take the approach, there's almost never an indication to consider surgery for a tendonitis that can be remedied a majority of the time by rest and or steroid injection. Again, just pictorially looking at decurvains at the base of the thumb is a little tunnel that the tendons that control the thumb run through, and this is an area that becomes painful with repetitive activity. Also known as mommy wrist or grandma wrist from repetitive lifting of newborns. Lateral epicondylitis or tennis elbow, another frequent entity. It's extremely common to see this incidence between the ages of 40 and 50. 1 to 3% of the general population will present with it. Probably 7 to 8% of manual laborers will have this. But the incidence of tennis elbow is significantly higher by the time we hit the 40 to 50 age group. The good news, if you look at response at 1 year's time after onset, 80 to 90% will resolve spontaneously if you do nothing, or if you do any other form of treatment. It is predominantly going to be pain with wrist extension and a lift grasp type activity. It's on the outside aspect of the elbow. One can consider numerous ways to treat this. You can go into direct stretching, counterforce bracing, and therapy for modalities, non-steroidals. Injection will be extraordinarily effective at shortening the time to an outcome. However, some studies in the literature suggest that injection will predispose to an increased likelihood of recurrence. PRP has been used, shockwave therapy has been used, surgery has been used. All of these really are forms of things that certain folks have tried for the entity. Primarily, the best treatment is rest and behavioral modification. Avoidance of the activity brings about a good level of resolution with minimal treatment, more reliably than any other form of treatment. Trigger fingers, nothing more than a tendonitis that is a pain and a locking or a catching of the finger, usually in a flexed position. Most commonly happens in the middle finger or the ring finger. It's frequent in the population over age 50. Probably the most commonly associated entity with trigger finger is being over the age of 50. Underlying diseases, hormonal imbalance can go along with this as well. Repetitive activity, gripping, or prior trauma to the palm can increase the incidence of this occurring. Primarily, these folks will complain of nighttime or early morning catching or snapping in pain. And as the hand continues use during the day, generally symptoms will begin to subside. Best treated with resting, non-steroidals, night splinting. A course of that for 6 to 8 weeks gets about 50% of folks better. Corticosteroid injection, very painful, much like the decrevans, but again, about a 98% effectiveness rate within 1 to 2 weeks' time. Surgery for trigger finger, probably only appropriate in someone who's failed injection. Repetitive motion compressive neuropathies. Now we come to the infamous cubital tunnel syndrome, which is the ulnar nerve at the elbow, or radial tunnel syndrome, which is radial nerve around the elbow. And there are other and sundry miscellaneous compressions. With poor ergonomics and home workstations, thoracic outlet syndrome also begins to occur. Carpal tunnel syndrome is the most common compressive neuropathy in the upper extremity. 3 to 6% of the general population has this. The incidence of carpal tunnel syndrome increases with age. Carpal tunnel syndrome predominantly is going to be numbness and tingling and occasionally pain. Primarily, as seen here in the blue depiction to your left, it is a numbness that occurs in the thumb, index, and middle finger, and a portion of the ring finger. Generally will exclude the little finger. However, a lot of patients, when they flare with their symptoms, especially at night, will say their whole hand is asleep. And it comes down to a good physical examination to really find out what's going on. Looking at the right side of the picture shows you what the carpal tunnel is, a tight space within the palm and wrist where the tendons, which bend your fingers and thumb, run through, along with a bunch of tendon lining, and the median nerve, which is the compressive entity. It is nothing truly more than a repetitive swelling of the lining of the tendons that puts pressure upon that nerve and creates the symptoms. I believe it was 1936 that Gertrude Stein said, "A rose is a rose is a rose." A carpal tunnel is not a carpal tunnel. It's not a carpal tunnel. They can be completely different entities. The chronic, I'm over 65 or 70, tendon lining response to underlying processes is totally different than the repetitive motion entity in the 30-year-old assembly line worker, which is totally different than I have a diseased tenosynovium from my rheumatoid arthritis that causes pressure. It's the same presentation and entity, but totally different underlying problems. So all of that needs to be taken into consideration as one looks at carpal tunnel syndrome. Treatment options, initially night splints, carpal tunnel injection, extremely diagnostic, can be therapeutic, electrodiagnostic workups, the infamous EMG, surgery if it is failing to respond to conservative treatment. We get into the chronic problem of amount of off work time that results from carpal tunnel syndrome. Return to work varies significantly based upon the activity after carpal tunnel surgery. On an average, by about 12 days, one can easily return to modified duty, but full duty returns will have a lot to do with what the full duty entails. The technique of release can have some impact, but is not complete. If you get to the next little bottom line in the slide, John Agee, who came up with one of the systems used for endoscopic release in the very late 1980s, his initial study looked at an average of 21 days to full duty in a non-workers' comp crowd and 70 to 77 days in a workers' comp crowd. A lot has to do with the activity. Full duty return as a hand surgeon is different than full duty return for an auto mechanic or diesel mechanic, which is probably totally different than a line worker. The bottom line of carpal tunnel syndrome is that we look at who fails treatment. Why do people not get better with surgery? Generally, wrong diagnosis. The correct diagnosis very, very much matters and is a compilation of listening to the patient, a good physical exam, and then weighing in the validity of diagnostic tests to come up with a bottom line conclusion. Again, the correct diagnosis very much matters. EMGs, which if you're screening for workers' comp, oh gosh, you have to have an EMG to have carpal tunnel. Based on which study you read in the literature, there's a 3 to 15% false positive and a 3 to 15% false negative rate to those testings. A lot has to do with the ambient room temperature when the exam is done. Trying to use ultrasound or MRI has also been advocated by some for this diagnosis. The infamous MRI report. Please remember, the report of an MRI is the impression of someone who has never met or examined the patient. They are looking at shadows on a screen. Therefore, they're an impression. It is never a diagnosis. Testing may help a clinician support a diagnosis, but should not be the only reason that a diagnosis is affixed to something. MRIs have a very significant high level of false positive pathology occurrences. Probably best study in that is rotator cuff tear and tendonitis in the shoulder, where David Ring, who was at that time at Mass General and Harvard, did a study having MRIs done on both shoulders and found a higher incidence of abnormalities in asymptomatic shoulders than the shoulder with symptoms. Therefore, interpretation has to be very, very guarded and not accepted as a diagnosis. Cubital tunnel syndrome, if we go back and think about that blue area on the hand from carpal tunnel, cubital tunnel syndrome gets the rest of the hand. It's the little finger and part of the ring. It also controls the small muscles of the hand, which may develop weakness or clumsiness or even spasm, and oftentimes some inside elbow pain associated with it. Cubital tunnel syndrome frequently noted on electrodiagnostic testings by percentage of drop-off stimulation above and below the elbow. Primarily, cubital tunnel should be first treated with a nighttime or symptom time extension splint. This will resolve 80 or 90% of patients with a 1 to 2 month period of splinting. Surgery is appropriate if the rest of the exam appears abnormal or if symptoms recur after an attempt and proven improvement with splinting. Radial tunnel syndrome we get into because it is frequently confused with tennis elbow. Tennis elbow will be lateral elbow, point tenderness on the bone. If one goes into the extensor forearm just below that point, that is where radial tunnel syndrome occurs. The radial nerve passes through the supinator muscle and can become compressed or irritated, especially with repetitive twist activities. EMGs, when done and looked at in this area, are almost always normal or non-diagnostic. Radial tunnel syndrome is predominantly a clinical diagnosis. It may be supported by local injection, but primarily clinical diagnosis. Quite debilitating when it occurs. Primary forms of treatment are going to be rest, therapy, nerve gliding activities, and this will make over 95% of patients better. This 35-year practicing surgeon has only seen 4 patients in his entire career that really needed surgical intervention. And there are some surgeons who don't believe radial tunnel even exists. I happen to be one that at least this month believe that it does exist, and the primary treatment for it is behavioral modification. Okay, the ergonomic workstation. How many of you have truly a good workstation at home? And you have to ask yourself this question. Mine's terrible. Mine increases shoulder abduction or lifting because I put my keypad in the wrong spot. And that increases the likelihood of thoracic outlet compression or compression of brachial plexus in the shoulder region. But again, all of the things we're looking at are coming up with comfort level, and it is amazing the uptick of repetitive activity, compression, and tendonitis that we've seen since we've all been working at home. I think my practice is probably doubled because of the stay at home and work at home modification level. Ergonomics on the workforce line are no different than the computer station. There you'll find increased incidence with a shorter stature working at a workstation unless one uses a step up. So all of these things have to come into play. Okay, now we get down to the standard aspects of what gets cut: lacerations, skin, muscle, ligaments, tendons, nerves, arteries. Basic looking at the hand anatomically, there's a whole lot of stuff in there. On the sides of fingers are nerves and blood vessels. In the centers are the tendons that control motion. As we get into the palm, some of the major blood supply to the fingers will run through there adjacent to the nerves. The muscles are deep within the structures. They're actually between the bones and create our fine dexterity motions. All of those structures with lacerations can classically be cut. It's a demonstration of a chef slides on his knife and cuts at the 2 white lines you see to your left. In his case, he took out his flexor tendons and could not bend his fingers any longer. This is a terrible off-work time injury. Tendons, if repaired at 3 months, can show you extremely good motion of making a fist and extending. However, those tendons are extraordinarily weak for at least 6 weeks to 10 weeks time after they've been repaired. One has to have good compliance with therapy in order to increase the likelihood of a good outcome from this. Nerves and arteries when lacerated. Nerve injuries usually involve diminished sensation, loss of dexterity because of that, susceptibility to repeat injury, or loss of muscle control based on what level the nerves are injured at. Artery injuries primarily will involve delayed healing and nerve recovery and the potential of long-term cold intolerance. The results basically are dependent upon the level of trauma, the extent of the trauma, and the age and the motivation of the individual. Nerves that are injured will never, ever, ever recover to normalcy. The best recovery, if a nerve has been lacerated or crushed, will come about in the under age 25 group. The worst outcomes are in the over 65 group. When a nerve is injured, it will recover at a rate of about 1 inch a month if it is appropriately aligned and or repaired. Basic example showing large neuromas that have been taken down from a nerve post-injury, and the nerve undergoes repair. This was done in a digital nerve on a thumb. The good news is its recovery time is going to be about 2.5 to 3 months after surgery. However, its re-education time will be probably closer to 1 year, since the recovery of intact nerve function versus the quick recovery aspect are totally different and are basically involving reorganization within the brain. Puncture wounds, this is what happens when the Sawzall blade falls off your Sawzall and stabs you at the wrist. It kind of punctures itself in that fashion. This young lad was lucky enough that he actually missed all of the important structures within his hand with that blade. Once it was removed, we were able to assess all of that. However, these are extremely prone because of the depth of infection. Puncture wounds, when they puncture the skin, drive other things within, including pieces of glove, clothing, dirt, grime, bacteria, and a high incidence of infection. Puncture wounds primarily should never be closed, but left open to close by secondary intent, and be left open to be able to drain to lower the likelihood of infection. Amputations, avulsions. Here comes the gross pictures for those that are worried. The barf bags are underneath the seat. We can talk about fingertip amputations, whole fingers or thumbs, hands, forearms. I've got a few of those things thrown in here. The mechanism of the trauma, the amount of injury, basically will have a lot to do with the ability at recovery and restoration of function, the commitment of the patient to a rehab program. These are oftentimes 6 to 12 month bare minimum adventures till when it reaches an endpoint. Okay, this is a fingertip amputation. That fingertip came off in a cabinet door that the owner basically slammed his index finger into. Treatment options for this acutely, one could just go with an open wound technique of putting a Band-Aid over this or a dressing. If you wish to go with the now popular Canadian treatment, it's a little Vaseline to keep the wound wet, and you wrap it up with Coban, a la Don Lalonde. One could tack that piece of tissue on knowing it won't survive, but it will form a scab and let the wound heal beneath. One could shorten the bone and get a primary closure, but then a different fingertip. One could be very exotic and put skin grafts over the wound or flaps, trying to reconstruct this. Actually, the best long-term functional outcomes come from an open wound technique of letting the body heal by itself. However, it will take longer, on average 30 to 45 days time. Here's that same individual showing you what he's like on day 1 or 2 to the left. By day 20, where the wound is beginning to contract and advance the tissue, which is sensate over the area. And there he is showing you what he's like at day 40. In essence, healed, but still a little crusty and hyperkeratotic, or a little extra callus in the area, reforming the fingertip. And here's that same fingertip at 2 years' time, showing you almost a complete remodeling until you look at the end-on picture to your right, which shows you there is a slight alteration in the overall fingerprint, but otherwise an extremely functional fingertip. This individual who happened to not only be a cabinet builder, but also a hand surgeon, treated this injury with a couple of Band-Aids and went right back to work in that fashion. Part of the problem is if we're going back to a heavy activity, we can't necessarily do that with our open wound and our open wound dressing technique. However, if we can modify and limit our activities, we can be there very, very quickly. However, overall outcomes are at least 6 to 12 months, which is the normal wound healing time. This is what happens when you run out of sawhorses. And this is what happens when you reach up there to find that out. Or in a avulsion injury, this is an arm ripped off in an engine boring machine. In this case, not a salvageable type entity because of the level of trauma, but tissues were used from that to basically salvage a functional below elbow stump. In this case, one of the things we look at with an acute flap reconstruction like this is an attempt to salvage an elbow, since prosthetic use, which this individual was doomed to at the time of injury, is significantly better if you can salvage the elbow. Above elbow amputees have about a 10% likelihood of prosthetic use versus below elbow amputees who are at 90 to 95%. Or we have somebody whose thumb's ripped off in their punch press and not reattachable. In that case, rebuilt with a piece of toe to come up with something that looks like this. Or as we look about 6 months down the road, something that functionally looks like this. The thumb's about 50% of our overall hand function, therefore its presence is quite good. And I think none of these things ever look really great. I think most of them always look like a toe. However, their functional level in a younger individual is quite high. Thumb pulp, taping merely a flap of tissue from a toe and putting a skin graft on a toe to restore just the sensate bottom part of the thumb, showing you regaining motion and regaining durable skin with sensibility. Now we get on to fractures, dislocations. This can be I fell on a wet floor and I broke my wrist, or this is I got my fingers caught and jammed or twisted. The most adverse outcome from all fractures is stiffness. All fractures and dislocations have a significant soft tissue injury associated with them, and all of them heal by making scar tissue. If that scar sticks the tendons and the soft tissues to the fracture, you get extremely stiff. One of the most significant adverse problems is prolonged splinting into stiffness. The earlier the motion is restored, the more profoundly the stiffness will be reduced. The finger extensor mechanism on the back aspect or fingernail side of the fingers is extremely prone to adherence in these areas. Dislocations, number one has to reduce the joint and restore the anatomy. Most dislocations are nothing more than a grade 4 level sprain. Early mobilization is probably preferable if joint reduction can be maintained. However, one has to control that arc of motion to prevent repeat dislocation. Initially, splinting rigidly for 2 or 3 days is appropriate, but after that, some level of motion will be necessary to maximize the functional outcome. Most common problem we see with dislocations is the patient who comes in 6 weeks after self-reducing their dislocation and says, in the last couple of weeks, my fingers gotten more puffy, more sore, and it's moving less, because someone got them splinted and no one explained the concept of mobility to them. So controlled aspect of scar formation and mobilization is extremely important for dislocations. Fractures, based on whether or not they are displaced, and the fractures you see here are both significantly displaced or non-displaced. Are they stable or unstable, which means if they're in a reasonable alignment, will they stay there? Are they open or closed? That means, are the ends of the bone sticking out through the skin or just tenting the skin? And is there malrotation or malposition or deformity, which means if the fracture is the little finger, but it is pointing out at a 90-degree angle, that is something that is grossly displaced and needs treatment. A stable fracture or a fracture which is restored to stability can be treated with early motion. Early motion will lower the likelihood of stiffness. One of the worst things occurring is intervention in one form or another, which creates more scar and more potential stiffness, followed by rapid application of splints and no motion. Really, I think everything was very much revolutionized by a Canadian program of the mid-1980s of buddy taping. The concept being you used an uninjured finger to help protect the injured finger and to help mobilize the finger. All fractures have scar tissue from the soft tissue injury. Scar adherence creates the stiffness. Early motion will reduce this. Controlled motion in the form of a buddy tape is probably the more preferable way of treating a majority of finger fractures. If the fractures are grossly unstable, a la this hand, which sat under a punch press for about 3 minutes, breaking across the joints, dislocating and fracturing things, those need to be appropriately aligned, and those pins you see across there hold those levels of stability, but they then permit early mobilization of the fingers to occur. If one does not try to early mobilize after intervening as such, one will obtain only more stiffness. Is this a fracture or is this a sprain? This is one of my favorite things to see in the office. There is a little tiny, minimally displaced fracture at the bottom of this joint that actually occurred with a dislocation or dislocation that returned and self-reduced. If this is treated long-term in a splint, there will be profound stiffness with this injury. As long as the joint is concentric, which it is, this should be treated very rapidly with early mobilization to prevent stiffness. The amount of soft tissue injury that occurred to that joint is far significantly higher than the amount of injury that occurred with that small chip fracture. So in this case, one treats this as a sprain, protects but rapidly mobilizes to get the best functional outcome. And if one goes back and looks at the Miller criteria, all sprains resolve at 6 weeks. It's interesting, all sprains heal by making scar tissue. And scar tissue is at its maximum production at 6 weeks, but does not resolve for 6 to 12 months. It's a great quandary that some of us clinical taking care of patients have with what the written criteria say. The end outcome of a sprain is 6 to 12 months' time. The bottom line for fractures, dislocations is therapy, therapy, and therapy. And when you're done with that, some more therapy. Okay, do you have questions at this point?
I haven't we haven't received any questions yet, but if anybody does have a question, you can type it in the Q&A part at the bottom of your screen or in the chat. I just had a question. Have you noticed you said it's increased your business, the whole work from home. What's the most common thing you're seeing people for right now?
Numb, achy hands, increased lateral epicondylitis from working in a bad position with the elbow, an increase in carpal tunnel complaints, an increase in tendonitis complaints, and definitely an increase in thoracic outlet type symptoms. And that is primarily numbness in the middle ring and little fingers that comes from malposition, a bad workstation.
So I shouldn't be working in my bed at night on my laptop without.
Oh, it depends on where your laptop is located and where your arms are located in relationship to the rest of your body. If your workstation is set up like my home workstation, which is absolutely terrible, then you will indeed start having symptoms probably within 5 or 10 minutes of beginning the activity.
Stacy, we had a question come in and you might be able to help with this one too. So obviously with all the required increases to work from home, how is that working with like BWC claims? Is the employer still liable for this claim? And if so, are employers working on plans to make better work setups at home for their employees?
The answers are yes and yes. If you have employees who are working at home doing work for you and you are compensating them for that, and the rules are still the same. Was the injury developed in the course of and arising out of their employment with you? Injuries like what Dr. Nappi has explained are definitely related to the workplace. And obviously every claim is individual and they all have specific circumstances that have to be investigated by the claim rep and a determination made there. But yes, certainly. And should the employer be, if this is going to be a long-term situation, having employees working from home, should the employer invest in making sure that those workstations are ergonomically correct? The answer is yes.
Is that something that the BWC could assist employers with?
Well, indeed. Obviously now we have everything is virtual at this point, but we do have ergonomic consultants, and the one for this territory is Julie Reynolds, and she is wonderful and amazing. And if you have any questions about how we can help with these particular situations, I would encourage you to reach out to her. I don't have her phone number at the ready right now, but I can definitely get it to Miranda and she can circulate it.
Wonderful, thank you. I do have Julie's contact information, so I
Perfect.
can send that out this afternoon when I send the presentation and the recording from today. Are there any other questions? I don't see any coming in. Just thank you very much for taking the time out of your day today, Dr. Nappi, to help us. It's very relevant with what's going on today's society. So thank you very much.
I thank you guys. And again, I can't overstress the ergonomic design of the home workstation right now.
Wonderful. Stacy, do you have anything else to add before we sign off for today?
That's it. I appreciate the time. Thank you.
Wonderful. We will send out the video, the link to everyone to watch once we upload it to the Chamber's YouTube. I can send a copy of the presentation as well and the upcoming BWC information, webinars and such. So thank you all, and we will see you next month on the 3rd Thursday at 11:30. Thanks.
Thank you.